Dr. London is calling.
Hey everyone, I'm Jovante. If you don't know me, I went to school with London and I went to BCom. So I matched into PM&R at SUNY Downstate, and then I did my IM prelim year at Richmond University Medical Center in Staten Island. And, you know, London and I were just talking, and not a lot of people know what PM&R is. And so I had some time. So we're just going to talk about PM&R. So PM&R stands for Physical Medicine and Rehabilitation. It's also known as Plenty Money and Relaxation, and it's a pretty cool specialty. I think anyone who talks about their specialties don't say theirs is cool, but mine is cool. It's really fulfilling and rewarding. So like an overall like rundown of it. So physical medicine and rehab, we work with a lot of patients, and I like to say, like, I describe it as you get a lot of your patients, especially inpatient wise, at their worst, and you get to see them either get like better and you see like a new normal for them or try to get them back to normal. With this, you're going to work with physical therapy, occupational therapy, speech therapy, neuropsych, neurology, ortho. Work with a lot of different internal medicine. You work with a lot of people, and it's like I also like to tell people that you're like the quarterback of the team, especially in the rehab unit, like PT, OT, speech therapy. They come talk to you. They say, hey, like this patient, like physical therapy, I love a lot because they can tell you your patient is like rehabbing, say they had a stroke and they're having like a lot of spasticity and their tone is really increased, right? So their tone, like they're like this, and you're trying to help rehab them for they can like get function back in their arm. Your physical therapist can come talk to you at your like team rounds every day and be like, such and such patients, we're trying to get them to hit their rehab goals, but they're having a lot of tonicity, like a lot of spasticity. And that can allow you to do like Botox injections, maybe do increase in like baclofen, or you get the problem solve, figure out what works, what doesn't work, what's the dosage. Different specialty as well. Like the main one I think everybody knows about is pain. I actually don't like pain. That's just me because just me. But it's funny, I don't like pain, but like I could consider it after my other specialties, but we'll see. I could do like another fellowship in it. But you can fellowship in pain, you can fellowship in my favorite, cancer rehab. Cancer rehab is really cool because you get to work with patients like following their cancer, debility, like their weakness, help them like get back to life. I think when I was on cancer rehab rotations, I saw a lot of like transplant too, which is pretty cool. Like transplant people were coming over and you like help with their debility, their fatigue, trying to get them back to another place. Yeah, with cancer rehab, you have like a different specialty, and that's a lot of inpatient. Trying to learn if I can do inpatient and outpatient. That's what I'm trying to learn. Pain management, you do a lot of um, just pain procedures like nerve blocks, injections. I know a lot of people love that. Interventional spine, same thing. Nerve blocks, injections, geniculate nerve blocks. Those are actually like a lot. One thing that you guys could look into that I've heard about is a pudendal nerve block, because a lot of people actually need that, but not enough people go and learn that. That's actually something I'm looking at learning because that's great UDP for your practice. So we did cancer, pain. There's amputee, like there's like amputees, but you see a lot of more amputees. Or sorry, amputee or residual limb. I've learned that residual limb is kind of like the better name as it, so I'm sorry about that. Then we have you can do HIV. So you like work specifically with people with HIV and their transplants. You can do that. You can do those are like some of the main ones. Oh, brain injury, spinal cord injury. I'm sorry. And those are two actually we're really interested in. Brain injury fellowship, where you specialize with brain injury and you just know how to manage all the brain injuries, from a stroke to meningiomas to anything that you can really think of, any tumors in the brain. Spinal cord injury, I love that. I would definitely work with spinal cord injury. And that's like a lot of people as well. Like I've seen a lot of young men gunshot victims with spinal cord get paralyzed or paraplegia or tetraplegia, just depending on their levels. And you can see like autonomic bladder. I feel like it's not autonomic bladder. I think I just made that up. It's like autonomic dystonia or something like that. But I think I just said autonomic bladder. Outside of this, oh, you can do sports medicine. I am so sorry. It just popped in my head. A lot of people, yeah. Sports medicine is another way. Say fields, but yeah, there's different fields. Like you see all these different fields in PM&R. But basically, how it works is your first year, so PGY2, um, you do mostly inpatient. I think you do like all inpatient. Some programs you can do pain. It depends if the program's like pain heavy, but you do all inpatient. So you learn how to work with bladder, like manage someone's bladder and bowel. I want to do inpatient, so I have to know that. Know how to do their spasticity. You learn how to do spinal cord injuries, brain injuries, how to handle the strokes, how to like, you just learn a lot of different inpatient things. But that's when you get to like really, really, really work with PT, OT, speech, and you see these patients every day. You see how they recover. You see them improve. Like when they get there on day one versus when they leave, like day 8, day 9, day 10, day 14, day 20. You never know. I say like 20 for like really the VA. The VA lets people stay way longer, which I thought was really cool. But mostly people stay like for 1 to 2 weeks. And there's also different types of rehabs as well. The thing is just like to tell you about the PM&R aspect of like you get to go through these different like rotations. You do a lot of inpatient that transitions to outpatient, your second and third. Your PGY3 and PGY4 year, sorry, because like a lot of PMRs start PGY2. So PGY2, you're mostly inpatient. You're like all inpatient really. PGY3 and 4, you're inpatient, outpatient. PGY4, I think is mostly like outpatient. You get to do like what is it? Call. Yes, call. Depends on your program. Some people do 24-hour in-house call and you get the next day off. Some just do home call where you literally leave. You're on call at home. You just wake up in a minute, might send a text. You're good. Like, oh, they want Tylenol? Here, prescribe the Tylenol. You go back to bed. But then you don't get the next day off. Some people, they have nurse practitioners in their pre-MR program. So when they're on call at night, a lot. Actually, yeah, I've seen a lot. At call at night, you have like an NP with you, which is pretty cool. They'll call the NP first before they call you. Um, and you're part of the team. You see them sometimes more than their family sees them, depending on their schedule. But their family comes. The family gets to know you. You get to know them. You get to spend time with them. You get to learn about a lot about your patients, which that's one of the most rewarding things about rehab. And also seeing someone like if they came in with like a stroke and they can't move their left arm and their left leg, and then it's like day 13 and they can kind of move their left arm better, they can move their left leg better. That is a rewarding feeling because you were helping with that process of improving, and then they still have a long recovery after, but you were there to help them and you kind of see them at their lowest point. And it's also like your responsibility to help keep them motivated, help keep them going, and being the best person that you can be to help educate them and be there for them. PMR has a lot of avenues as well. So with PM&R, we have certain procedure hours that people don't really, I think, know about. I don't know the hours off the top of my head, but I know I have to do EMGs, and you can be an EMG specialist as well. So like that's really cool with upper arms and lower arms. To me, it gets kind of like repetitive, but a lot of people love it too. You get to see like a lot of carpal tunnel. So you do EMGs, you do ultrasound guided injections. Those are really cool. Ultrasound guided knee drainage. That's really cool. You do your nerve blocks. You do peripheral nerve stimulators. You can do what else? I mean, like pain injections, like knee injections. You can do a lot of those things. That's the really cool part about it. And sports medicine is like in the same thing. So you can work with athletes. You can go on that avenue. There's some PMR doctors that literally become like Olympic team doctors, like for curling, for soccer. Like some PMR doctors go PMR sports med and then do that. And that's pretty cool. Like it's an open avenue and it's kind of like what you want to do and where you want to go. So me personally, I wanted to do cancer rehab because my mom had cancer and I saw her go through that. And well, she had a tumor. Yeah. Basically, she had a brain meningioma and she saw a cancer rehab doctor. So, it's a benign tumor. But that was cool to see. And then we see like people go through brain injuries. I've seen a lot of that. I've seen a lot of spinal cord injuries. Actually, I was team spinal cord injury until I did like a cancer rehab rotation. Um, One biggest thing is like barriers. If someone had a stroke, if they live in a 3-floor house, we have to work with social work. Oh yeah, social work's a big people we work with. Social work. Um, work with the barriers of the house, how to like get them a toilet seat, how to do they need to leave move houses, do they need a ramp, do they need a wheelchair accessible car for someone with a spinal cord injury. So you work with a lot of these things too, where you talk to the family. The sad thing I think you do deal with insurance a lot behind the scenes. That's the sucky part. But outside of that, like I think how much I deal with insurance, seeing the patient, seeing them improve, that's better to me. We also can determine like where people go outside of rehab. So what I mean by this is say someone wants to do like your own consults and consults, you get consulted, you come and you're like, oh, this patient is doing such and such, like they had a stroke. We want to know where should they be the like what is it discharged to, and you can do subacute, acute, or skilled nursing home, LTAC. Acute facilities, I believe there might be wrong on this. I think acute's up to 2 weeks. It's either acute slash subacute, but I'm pretty sure it's acute's up to 2 weeks. Skilled nursing home, that's L with the acute rehab. A big thing is you have to do physical therapy for 3 hours a day, 5 days a week. So 15 hours a week. If you miss a day, they make it up on the weekend. It just depends on the patient, like their schedule when they came in. Then we have skilled nursing home. I believe it's less. I think it's 2 hours. I want to say it's 2 hours, and it's like maybe 8 to 10 hours a week. I'm not pretty sure on that. I rarely have sent people to skilled nursing homes. I really send them like acute or they go to LTAC, which is long term. And long term is like people who have like complications where they still have to like be watched 24/7. Sometimes you need like someone on a ventilator could go to LTAC technically. I think I've seen that once. I've also seen 2 acute rehabs have ventilators. So it really depends on your hospital. Like you can fellowship in sports med, brain injury, spinal cord injury, cancer rehab, um, spasticity, EMGs, pain, interventional spine. I think I'm at like 8 right here. That's like 8 different specialties. If I'm missing one, you might. Oh, HIV 9, amputees 10, ALS and MS clinic. Like if you want to specially do that, that's 11. Like you can specialize in a lot and kind of like create your own practice. You can also learn from a program where you can just come out and you can just go straight into practicing as a PMR. You can be a general physiatrist and yeah, general physiatrist and have enough like knowledge and like learn brain, learn spinal cord injury, learn all these different things. Like you see them and you learn them. They don't go like, I mean, you can go to pain, you can go to sports med, obviously, but like see if you can do a program where it lets you do 2 weeks pain, 2 weeks like sports med, and 2 weeks inpatient. Like see the inpatient side, see the rehab side too. Like see that side and see the outpatient side. And I think you'll see like the difference. Like it's pretty cool where like if they're outpatient, like pain, like you don't like you send them PT and like OT and stuff, but you don't daily get to see them do it every day versus when you're an inpatient, you get to see them do it every day. Like you get to see the inpatient PT, the inpatient OT, you get to see how that patient's rehabbing every single day. And that's really it for PM&R. So you have these specialties, you have this, but that's kind of why I went into it. I like there's more reasons too, but it's a really cool specialty, really, really rewarding. I think the reward fulfillment of it was the best. I also was an athlete, so like working in a team environment is like something huge for me. And I think for me, PMR is just something about like having your weekly team table rounds, and you're sitting there talking about a patient like such and such, day one, now we're day 7, and they improved. Do we keep them? Do we let them go? And yeah, that's really it for PM&R. If you guys have any questions, let London know. She'll probably shoot me a message and ask me. That's kind of like an overview, overall, like simple version of PM&R as well. Take care. Good luck on whatever y'all doing, and bye.